the practical issues. Let us start with a case scenario. An 18-year-old girl diagnosed to have a hole in the heart in infancy had frequent LRTI, initially on medications, later became better to the extent that the patient was off drugs, but recently has progressive dyspnea on exertion. So the patient as well as the parents initially believed that things are better, but not exactly. Questionable cyanosis, saturation 85%, no cardiomegaly, S1 normal, single loud second heart sound, and ejection click, and a short ejection murmur, insignificant in the pulmonary area. Obviously, the diagnosis is a VSD Eisenmenger. Similar clinical scenario, 19-year-old girl, improvement after the initial phase, but only thing is there is a difference in the oxygen saturation. Just a second, I'm having a little problem with the... Okay, no obvious blue color because the upper limb, the saturation is fairly normal, 95%, but lower limb, it is 82%. So there is a differential cyanosis and a differential clubbing, if also we can look for that. Okay, and that is the data. There is a difference between the right radial and the left radial. The right radial, it is nearly normal. The left radial is 86%, and in the femoral, it is even lower down. And obviously, it is a PDA Eisenmenger. We know that though we tell about differential cyanosis, it may not be there all the time. Multiple reasons for that. Only around 50 to 60% of PDA Eisenmenger have the real differential cyanosis. And always look at this important difference between the right radial and the left radial. What exactly is Eisenmenger syndrome? In the classical thing, initially there is an increase in the pulmonary blood flow. Exposure of the pulmonary vascular but to the systemic pressure, high pulmonary artery pressure, that leads to pulmonary vascular remodeling, pulmonary vascular obstructive disease, and reversal of shock. So every patient need not exactly do like that because around 10 to 15% of VSD Eisenmenger may not have the initial phase of frequent respiratory infection, neonatal heart failure, and all that. The Eisenmenger syndrome was described more than 100 years ago. Victor Eisenmenger, 1897, Paul Wood, the important article published in BMJ 1958, the Groenian lectures, the two-part article. I think you should read Paul Wood for the full description. The old books are still available. The newer editions are not there. Initially, the Eisenmenger complex is actually VSD with Eisenmenger syndrome. Subsequently, it was expanded to include the Eisenmenger syndrome in 1958, which includes all the defects. So what is the standard definition of Eisenmenger syndrome? Pulmonary hypertension due to high pulmonary vascular resistance with a reversal or bidirectional shunt at the aortopulmonary, ventricular or atrial level. So the important part of the definition is a high PVR. It is not actually PA pressure because PA pressure, we know that in a post-tricuspid shunt, VSD and PDA, PA pressures will be systemic. It cannot be suprasystemic, but in ASD Eisenmenger, it can be systemic, subsystemic, or suprasystemic. So the cardinal thing is the PVR. How much should be the PVR? Roughly, it should be more than 10 Wood units. That will be equivalent to 800 dynes. So that is not part of the definition, but roughly it will be more than 10 Wood units. This will be a classification. The simple Eisenmenger syndrome. Pre-tricuspid, you have the ASD. Post-tricuspid, the VSD, PDA, AVSD, and the AP window. Then complex will be ventricular, single ventricle, DORV, and the great vessel truncus, and others you have the DTGA. Then there is a group of iatrogenic, post-surgical, palliative procedures. These are uncommon now. Earlier you have the central shunt, the Waterston Cooley, the port shunt, and all that. If you take the overall Eisenmenger syndrome, 2/3 is contributed by VSD and ASD. Around 15% will be PDA. So that will be altogether 75 to 80% by these three lesions. All others put together will be only around 20%. Presentation of Eisenmenger syndrome will be in the second and third decade, but it is established in the first decade of life for a post-tricuspid shunt. And early Eisenmenger syndrome, in a post-tricuspid shunt, especially with a DTGA, single ventricle, then truncus and all that, where, it's a complex admixture lesions. Delayed in a second ASD, it's a delayed presentation, the reason for that, maybe by the age of 25 years, 30 years, or even later. Life expectancy at 1 year, 97%, and at 25 years, it is 42%. Overall, you can tell that the life expectancy is reduced by around 20 years. But still the prognosis is much better compared to an idiopathic pulmonary hypertension, a primary pulmonary hypertension. So the normal survival is that yellow line, and the blue is the Eisenmenger syndrome. So life expectancy reduced by about 20 years, but not too bad. The mean age of death is 45 years. So the policy of non-intervention is important unless absolutely necessary. Avoid destabilizing the balanced physiology. 20% die during a medical procedure or ill-advised activity. That's a very, very important point. And the survival of Eisenmenger syndrome is much better than the idiopathic PH or primary pulmonary hypertension. This is old data. Now it could be slightly different because the treatment of PH has improved because of the specific treatments which are available. But still, overall, the outcome of Eisenmenger syndrome is better than the outcome of a primary pulmonary hypertension. The predictors of poor outcome, history of syncope, elevated right heart filling pressure indicating right ventricular dysfunction. So the prognosis is not primarily related to the PA pressure. The prognosis is primarily related to the right ventricular function. The moment right ventricular dysfunction develops and heart failure sets in, then the outcome is bad. And people with severe hypoxemia do not do well. So these are the important complications which we should prevent, and if present, we should treat. The various arrhythmias, again, relation to the age, endocarditis comparatively uncommon, heart failure a comparatively delayed phenomenon. Then cerebrovascular accident, cerebral abscess in any right to left shunt, both thrombocytopenia, which leads to bleeding, prothrombotic state, polycythemia, hyperviscosity. So you get both bleeding as well as hyperviscosity, hemoptysis, gout, cholelithiasis, renal dysfunction. Just to recollect, VSD Eisenmenger, fairly normal sized heart, ASD Eisenmenger, significant cardiomegaly, and in a PDA Eisenmenger, the aortic shadow will be prominent, the ductal shadow may be seen with an aortic ductal calcification, may or may not be present. The important key differentiating point, the age of presentation in ASD is beyond the third decade, VSD PDA much earlier. The gender ratio, females commoner with the ASD, spatting can occur in a VSD Eisenmenger, differential cyanosis such as PDA, prominent A wave in the JVP goes for an ASD, cardiomegaly goes for an ASD, precordial activity for an ASD, whereas with VSD Eisenmenger, usually it will be comparatively quiet precordium with no significant cardiac enlargement. Second heart sound, single in a VSD Eisenmenger and widely split in an ASD, though the degree of split can come down. TR murmur is commoner with an ASD. Cardiomegaly favors ASD. Prominent aorta favors PDA. Ductal calcium is pathognomonic of PDA. Now, QR in the ECG favors an ASD. Presence of a small Q in B5, B6, people tell that it is an indication of a bygone shunt, left-right shunt present earlier, could suggest a PDA. Now, the non-invasive evaluation to look at the hemodynamics, echocardiogram is very useful. It defines the structural abnormality. Very often the large defect, VSD or ASD, can be identified. PDA may not be always very easy to identify unless you are very carefully looking at that. Sorry, because once they develop PAH, then the Doppler measurement across the duct may not be very easy. We can calculate the PA pressure from the TR and the PR jet. Contrast echo with an agitated saline is very useful and can detect a right to left shunting. In fact, we all do that and it is very, very useful. TE is same and may be required in adults for precise delineation of the abnormality. And that is the TR jet. And one important point, many Eisenmenger syndrome, the TR jet will be very mild. Sometimes it can be very trivial. So that getting a good TR jet may not be very easy. You won't get a spectral display like that. So you should spend a lot of time looking at the TR jet. Because the TR may be mild, but when you look at the gradient, it may be 80, 100, 120 and all. So TR jet is utmost importance. Second point, look at the PR jet very carefully and try to find out what is the PR end diastolic pressure gradient. Because from that we can calculate the mean pulmonary artery pressure as well as the pulmonary artery diastolic pressure. So non-invasively, we get an idea about the pulmonary artery systolic pressure. You get an idea about the pulmonary artery diastolic pressure. So a lot of hemodynamic data can be obtained by echo Doppler. And the IVC should be studied in detail. The measurement of the IVC, inspiratory collapse, you get an idea about the right atrial pressure. So all these can be combined to get an idea about the real hemodynamic situation. The right ventricular function can be assessed. You can look at the TAPSE, you can look at the cavity dimensions and things like that. Now, invasive evaluation may not be required in every patient, but cardiac cath can be safely performed. Only thing you should be a little careful. It is not like, an ASD with a left-to-right shunt. You should be very careful when you perform a cath for a patient with pulmonary hypertension. It must be done in borderline cases operability, because all other things you can find out by a proper echocardiogram. You can understand the structural defect, measure the lesion, you can find out the left to right shunt, the right to left shunt, and even the calculation of the pressures, the resistance, everything can be done. But borderline cases, to assess operability, even now a cardiac cath and pressure measurements and oximetry will be required. And response on the pulmonary vasculature, pulmonary vasodilators like oxygen, tolazolin, and isoprenaline, those are the earlier things. Now nitric oxide is the one which is more useful. And always limit the use of the contrast agent whenever you are dealing with a patient like this. So looking at the hemodynamics, the pressures and the oximetry, the right and the left heart pressures, the mean PA pressure, the LA pressure to calculate the pulmonary vascular resistance. We know the vascular resistance, it is actually the pressure drop divided by flow. That is resistance. So resistance is equal to pressure drop divided by flow. So if you want to measure the pulmonary vascular resistance, the pressure drop is between the arterial side and the venous side. The arterial side will be the mean PA pressure, which you can find out. The venous side is actually the pulmonary vein, which is equivalent to the left atrium, unless you have some pulmonary vein stenosis or something like that. So that will give you the idea about the pressure drop across the pulmonary circulation. Divide it by the flow. The flow that is the cardiac output, whether it is 5 liters or 4 liters, which you can calculate. For example, if the mean PA pressure is 50 and if the LA pressure is 5, the pressure drop is 45. And if the pulmonary blood flow is, say, 4 liter, the vascular resistance will be 45 by 4. It will be something like 11.5, significantly elevated. That is how you calculate the vascular resistance. So vascular resistance is the pressure drop divided by flow. So on the systemic side, it is pressure drop across the systemic vasculature. So the mean aortic pressure, which will be roughly, say, 80 or something like that. And the mean RA pressure in a normal person, it will be something like, say, 5. So that is how you calculate the SVR. So in a normal person, say 85 minus 8, it becomes 80. And the cardiac output is 5 liters. So 80 by 5, you get the SVR 16. So you can calculate the PVR, you can calculate the SVR. Then it is very easy, the PVR by SVR ratio. Also, you can index it for the body surface area, that is PVRI and SVRI, which may be required in the pediatric age group. And the shunt can be calculated, the right to left, the residual left to right, and all those things. Right to left, not left to right. And many of these things can be non-invasively calculated by Doppler. Okay. Now we should understand that when you tell about pulmonary hypertension, the Eisenmenger Syndrome is actually a pre-capillary pulmonary hypertension. What is a pre-capillary pulmonary hypertension? The mean PA pressure is more than 25. The left heart pressures are normal. The pulmonary capillary wedge pressure, that is the equivalent of the LV filling pressure, the LA pressure, that is less than 15. This is, what you get in a type 1 pulmonary hypertension. In the idiopathic variety of primary pulmonary hypertension, they are all pre-capillary pulmonary hypertension. Whereas post-capillary pulmonary hypertension, the pulmonary capillary wedge pressure is increased, indicating there is left heart disease. That is post-capillary. Mean PA pressure more than 25, pulmonary capillary wedge pressure more than 15. That is what you get in the type 2 pulmonary hypertension. Okay. Now, assessing reversibility is a very, very important aspect, but it is difficult many times. What you can use 100% oxygen, isoplanin, tolerasolin, or nitric oxide. There is some role of pulmonary angiography, and previously people used to do lung biopsy, which is not routinely done these days. So many times you may get value like this. The basal QP-QS may be borderline, 1.8:1, PVRI 5, SVRI 20. The ratio is something like 0.4. So you are not too happy. You give 100% oxygen, repeat the oximetry. You may find QP-QS has improved to 3.5. PVRI has come down. The SVRI ratio has come down to 0.25. So things have improved. So that suggests there is reversibility. So if this person undergoes a surgical procedure or an intervention, there is every likelihood that the pulmonary hypertension may regress and the pulmonary vascular resistance may come down. So this is how you look at the reversibility. But if there's no reversibility, then it may not be a case for surgical intervention. And this is the advanced vascular disease. I think the PGs, you should all be familiar with the Heath-Edwards classification, the very old one. 6 grades are there. The grade 1 is medial hypertrophy. Grade 2 is cellular intimal proliferation. These 2 grades are reversible. When it comes to the third grade, fibrosis sets in. That is intimal fibrosis, eccentric and concentric. From that point onwards, concentric intimal fibrosis, it becomes slowly irreversible. And the other complicated lesion beyond that, 4, 5, and 6 are not reversible. Previously, people used to do the lung biopsy or the lingular and all that to look at that, but it has very, very limited utility. Now, coming to the second aspect, the management point, the most important thing is that Eisenmenger syndrome is preventable because the treatment is not all that great. So this is something preventable. And, if the pediatrician and the cardiologists are all very careful, we are unlikely to miss these cases so that in later life they won't come with Eisenmenger syndrome. For those people, what can we do? Management strategies, the drug treatment, phlebotomy, and option of transplantation, heart as well as heart lung transplantation. Not heart, lung and heart lung transplantation. Then special issues like pregnancy, hormone contraceptive, issues related to non-cardiac surgery, high altitude flying, emotional upset, the problems. These are all the other important things. The first thing is you find out whether it is operable or not. Is it really Eisenmenger syndrome so that you cannot really offer anything? So the operability is based on the age of the patient, the type of defect, the QP-QS ratio, the PVR by SVR ratio. The crucial thing will be the PVR and the SVR, and in the pediatric age group, the PVR index for the body surface area. And let us look at the latest recommendation, ESC 2022. The recommendation for shunt closure, QP-QS, more than 1.5:1, based on the calculated PVR. If the PVR is less than 3 Wood units, no issue, class 1 indication, you go ahead with surgery or device closure or whatever it is. If the PVR is between 3 to 5 Wood units, okay, it's a class 2A recommendation, which is a reasonably good recommendation, but take all factors into consideration. Now, you have an ASD. PVR is more than 5 Wood units, and you treat that patient, and then the PVR comes below 5 Wood units. Or in the cath lab, you give 100% oxygen, tolazole nitric oxide, it comes below 5 Wood unit consistently. So you think there is good reversibility. Okay, you can go ahead with an intervention or surgery, but it's a 2B indication. You take all factors, you take the history, examine the patient, look at the X-ray, look at the extent of pooling, then find out how much of reversibility with the pharmacological intervention. Then one option is to treat the patient with sildenafil or the bosentan and all that, and reevaluate the patient. Okay, another thing will be a post-tricuspid shunt. VSD and PDA, PVR more than 5, may consider shunt closure even if it does not come below 5 Wood unit. There is a difference between pre-tricuspid and post-tricuspid. Pre-tricuspid, if it does not come below 5 Wood unit, you should be very, very careful. Ordinarily, you don't do surgery. So an ASD, PVR continuing to be above 5 Wood unit, ordinarily you don't do a device closure or a surgical intervention. But VSD and PDA, you have the option of careful evaluation, consider all factors, and then you may consider an intervention in a special situation. Now, ASD with PVR more than 5 unit, no controversy, it's a class 3 indication. So there is a difference between pre-tricuspid shunt ASD and post-tricuspid shunt VSD and PDA. ASD, pre-tricuspid shunt, PVR more than 5, no intervention. Whereas PDA and VSD, even if the PVR is marginally above 5, okay, you can consider after taking into consideration a lot of factors. Now, one important point, this is something, people have tried. In borderline cases, people feel that you can treat them and repair. You can treat them with the pharmacological treatment. You can give them bocetan, expose them to sildenafil, prostacyclin. Then the PA pressures may come down, and then do a procedure. Second, okay, you repair and then treat with the endothelial receptor antagonist and the phosphodiesterase inhibitors and all that. But limited data for all these. Now, there is an option of heart lung transplant in very highly selected cases. High mortality in the first year and very limited data. So either a heart and lung transplant, or you have an option of lung transplant with surgical correction of the cardiac problem. So lung anyway has to be transplanted. The heart usually done, but may not be all the time. Now, another area is the polycythemia, secondary erythrocytosis. We should understand that polycythemia is beneficial. So routine phlebotomy should be avoided. Symptoms of hyperviscosity with hematocrit more than 65% is the only indication for phlebotomy. Not any patient with hematocrit 68. No. And what are the symptoms of hyperviscosity? Neurological deficit. Most important one is headache. That is the most important one, headache. Other things will be syncope, seizure, ataxia, cerebral hemorrhage, tingling sensation, then visual changes like diplopia, retinal vein thrombosis indicating a prothrombotic state, sometimes retinal hemorrhage, sometimes mucosal bleeding. But most important will be hematocrit more than 65 with headache and sometimes giddiness and sort of ataxia. Then, okay, you have to do a vivisection. Now, how should you do a vivisection? You should be very, very careful. You should avoid dehydration. So, if you are removing 300 ml, then 300 ml saline should be infused. And be very careful with any venous, access, because always there is a chance of, it is not like a normal person. There is communication between the right heart and the left heart. So whatever you do on the right side can go to the systemic side and can produce stroke and things like that. So venesection, phlebotomy and all should be very carefully done in a patient with Eisenmenger syndrome. Another important area, Eisenmenger syndrome and pregnancy. This is SAT data kindly given by Dr. Sulfikar. Not only this data, most of these slides are provided by Dr. Sulfikar, my close friend. And this is the data of the SAT hospital, one Eisenmenger syndrome for 10,000 deliveries. So it's very, very uncommon. Maternal death, 2 out of 17. So that comes to, something like 25 to 30%. So very high maternal mortality. So if so what should be our approach? Prevent pregnancy. Marriage, a lot of discussion required. Contraception, the best will be a tubal ligation, because then the lady will not become pregnant. Or progesterone containing intrauterine device. And in case the patient becomes pregnant, then the antenatal care, most important point, avoid bocetan. In pregnancy, it is not safe. Proper hydration, lateral position, oral hygiene, avoid travel, high altitude, then peripartum care, anticoagulation, and all those things. Then plan for delivery near term, preferably by normal vaginal route with a shortening of stage 2. Meticulous attention to postpartum care, preferably in a cardiac ICU, if possible. Now, finally, the conventional treatment, which we all know. Digitalis, diuretic, antiarrhythmic, especially ASD, Eisenmenger, atrial fibrillation. You don't give antiarrhythmic like that. You try to control the ventricular rate because you cannot maintain them in sinus rhythm. You can only do a rate control, not rhythm control. Then anticoagulants. Then long-term oxygen therapy, whether it is beneficial or not. Correction of anemia. Avoid dehydration, very important. High altitude. Infection. IV line, extremely important. Avoiding pregnancy. And finally, vaccines, very important. Pneumococcal vaccine and influenza vaccine. And these are the current recommendations. There is only one class 1 recommendation even in 2022 for symptomatic patients with Eisenmenger syndrome, and that is bosentan. And remember, bosentan is a class 1 recommendation, whereas other ERA, including macitentan, they are all class 2A recommendation because the data is stronger for bosentan. Now, supplemental oxygen, should you give it or not? We know that giving oxygen will not improve the saturation. If there is an increase in arterial oxygen saturation, and if there is a real symptomatic improvement, okay, you give oxygen. It's a 2A indication. Now, supplemental iron, if there is iron deficiency, a 2A recommendation. How should iron be given? It can be given orally, or ferric carboxymaltose infusion can be given. How will you diagnose iron deficiency? Earlier, peripherals, we are looking at the hyperchromic microcytic anemia. The mean corpuscular volume will be reduced. Now you have the iron studies, the ferritin, the transferrin saturation and all for your health. Now the other PAH treatment, ERA, phosphodiesterase inhibitor, including sildenafil, riosigouad, prostacyclin analog, they are all class 2A indication. Now combining two, the ERA with PDEI, is also a class 2A recommendation. Now, what about oral anticoagulant? Many people give oral anticoagulant, warfarin. Actually, it's not a strong indication. Only indication will be Eisenmenger syndrome with pulmonary artery thrombosis. If there's no hemoptysis, even then it's a 2B recommendation.